So just returning to my, I can't tell you how this talk has been in my mind for the last 6 months. But after October 8th, 7th, and 8th, I became totally humbled by, what do I say to an audience that is doing the work? And Paula said to me, there's always time to go back to basics. And I will start by doing that. And towards the end, I will talk a little bit about the adaptations of child-parent psychotherapy that so many wonderful clinicians represented today by Naama and her team, Medabrin Beyahad, are doing. As Paula said, Patricia and I created child-parent psychotherapy starting in 1996. And Chandra Ghosh Ipen gave it wings when she developed the fidelity measures that facilitated systematic training and enabled large-scale CPP dissemination, first in the United States, then in Israel, and increasingly across the world. Today, I will use a typical clinical example to illustrate CPP theory and practice and show how the fidelity measures guided the treatment. I will then describe briefly how CPP clinicians in Israel are pioneering adaptations for the families suffering the unspeakable atrocities during October 7th and its aftermath. I chose to include treatment fidelity in my talk because Patricia was gifted at teaching this topic, which is often seen as obligatory and even pedantic in evidence-based treatment, training, and research, but which is essential as a roadmap for effective treatment. In late 2014, Patricia gave a masterful lecture to our Haruv CPP Train the Trainers cohort in Tel Aviv, where she showed how the fidelity measures operationalize the spirit of CPP. I remember trying to take notes while she spoke, but giving up because I knew I could not replicate her magic for breathing life into the measures. That was her last lecture, and the memory of it lives on for all of us who were there with her. I am picking up where she left off because we know from our sages that lo aleinu hamelacha ligmor velo anachnu chorin livatel mimena. We are not expected to complete the work, but we're not free to refrain from it. CPP responds to the sad reality that babies and children in the first 5 years of life are particularly vulnerable to child abuse, family violence, and accidental injuries. In the United States, more babies die from these causes in their first year of life than at any other age. And children under 5 represent about 40% of maltreated children in the child protective system. These children are often overlooked for treatment despite hundreds of studies that show that early trauma has long-term negative effects on brain architecture, stress physiology, cognitive and social emotional development, and mental health. The mental health professions still don't pay enough attention to babies and young children. There is little training in infancy and early childhood development and mental health in psychology, psychiatry, and social work programs. And there is a scarcity of clinicians with the skills to treat young children and their families. The promise of good treatment, as Patricia said so powerfully in the brief clip that Paula so beautifully shared with us is that it can create emotional safety and transform young children's developmental trajectory from psychopathology to health. But this can only happen with a well-prepared workforce of clinicians. And I am proud that Haruv and Israeli CPP clinicians are passionate about modeling and expanding such an early childhood trauma workforce that is so needed always, and especially now. I am trying to move, okay. In CPP, we work from the basic premise that the secure quality of our most intimate relationships is the foundation for the biological, cognitive, and social underpinnings of mental health across the lifetime. This is most apparent in young children who are completely dependent for their survival and healthy development on the adults who take care of them. Trauma can shatter the young children's developmental expectation of parental protection. And this is often an intergenerational tragedy that often becomes self-perpetuating. This is because traumatized small children most often have traumatized parents who feel unable to protect them. The failure to protect can stem from traumatic events that happen simultaneously to the parent and the child when they are together, such as a terror attack, or because parents become emotionally overwhelmed and feel powerless when a traumatic event puts their child's life and safety at risk, such as a child's near drowning, for example, or accidental injury, or because the parents themselves engage in domestic violence and child abuse in an intergenerational transmission of trauma that often stems from the parents' own frightening but unresolved frightening experiences. In any of these conditions, the quality of the parent-child relationship can serve either as a protective factor or as the driver of the child's traumatic stress, because the attachment motivational system is hardwired in our biological makeup. Freud described young children's trust in their parents' capacity to keep them safe as a protective shield, his words, protective shield, that filters the intensity of danger signals and makes fear tolerable. Traumatic events can shatter this protective shield, overwhelming both the parents and the child with the horror of what is happening. When the parents in the moment need to prioritize survival by fighting, fleeing, or freezing, they cannot attend in the moment to the child's signal of need. And this disparity in priorities between the parent and the child can create an alienating gulf in their subjective perceptions. This is often the origin of pathogenic mutual attributions between parent and child. Trauma brings an unbearable perceived reality to the universal childhood anxieties about separation and loss, losing love, body damage, and superego guilt, the early fear that bad things happen to us because we ourselves are bad. For the child, the rupture of the protective shield from trauma can mean, you can't take care of me, you don't love me, you will leave me, you will hurt me. And the terrifying fear is, I deserve it all because I'm bad. I will give you a clinical example from the treatment of 4-year-old Roger, who pretended to point a gun at his mother and said in a menacing voice, "Don't make me have to shoot you, mommy." He often hit not only his mother, but also his teacher and his peers. Roger and his mother were referred to our program by Child Protective Services after the neighbors called the police in response to the mother's terrified screams and the father's loud threats that he would kill her when she told him she was leaving him. The father now had a restraining order not to see his wife or child, and the child protective worker told us that Roger blamed his mother for losing his father. We also learned that Roger beat his nails to the quick, cried when his mother left him at childcare, and woke up crying during the night, thrashing about and screaming, "No, no, no." It was clear that Roger's inner world was in turmoil, and he was showing that to us in graphic behavior. He simultaneously loved, feared, and missed his father. He loved his mother, was angry at her, and feared that she would leave him just as she left his father. In her own distress, Roger's mother did not understand her son's confused feelings, and she focused only in his aggression, seeing him as the replica of his violent father and interpreting his nightly fears, beaten nails, and separation distress as additional signs of how wounded, how bad he was. When she was unable to control Roger's aggression, she yelled at him, "You are just like your father." And this triggered Roger's fear that she would leave him as well, and this exacerbated his anger at her in a precise imitation of his father's response to her threat to leave him. Child-Parent Psychotherapy was created to help children like Roger. The young children and parents referred to our program are highly traumatized, with an average exposure to 5 types of traumatic events for the children and 13 types of traumatic events for the parents. CPP has the motto, "Speaking the unspeakable," because putting shameful secrets into words, when done with deep care, opens the possibility of healing. The first phase of treatment consists of meeting alone with the parents for an extended assessment and engagement process that lasts anywhere from 3 to 8 sessions, but can be shortened in response to crisis and emergency situations. We call this initial phase the foundational phase because our goal is to lay the groundwork for the treatment plan by understanding how risk and protective factors, both psychological and external, show up in the parent-child relationship to protect or to aggravate the impact of trauma. During the foundational phase with Roger's mother, she told us that her own mother, father, and 2 siblings routinely hit her and called her names while growing up. Her husband promised to protect her, to rescue her, but he started hitting her when she unexpectedly became pregnant soon after they started their relationship. And then he started telling her that she was ugly and no longer desirable. He was turned off by her pregnancy. Roger, his mother, and perhaps also his father were classic examples of Selma Freiberg's ghost in the nursery dynamics, where the parents reenact with their children their own unresolved childhood difficulties. Decades of clinical and research evidence teach us that most of these parents can develop greater empathy for their child when they can safely re-experience in the therapeutic relationship the terror and grief that went underground for decades as a form of self-protection. During the foundational individual sessions, Roger's mother cried over her painful childhood as she remembered how frightened, helpless, angry, and alone she felt while being hit and insulted. And she gave very graphic examples of moments of tremendous fear without protection. The clinician guided her in using this affective remembering in the body, to understand the parallels between Roger and herself. She realized with great pain that Roger was now suffering the way she had suffered as a child. And she started to see his separation distress, beaten nails, and night wakings as expressions of fear rather than defiance and badness. Very reluctantly, she also began to accept that Roger loved as well as feared his father, just as she had loved and feared her own father. That Roger wanted to be like his father, and that he had learned to hate from watching his father do it to her again and again. The foundational phase culminates in a feedback session where parent and therapist put together what they learned to co-create a treatment plan. The message for Roger that the mother and the clinician agreed to was that his mother loved him and would not leave him, and that she gave him permission to love and miss his father, and that it was sad that nobody taught his father when he was little that hitting was not okay, and that Roger was now just the right age to learn to say what he didn't like instead of hitting. The treatment agreement marked the completion of the foundational phase, and Roger's mother was now ready emotionally to be a partner in the core treatment with joint sessions with her child. We use the term CPP, clinical formulation triangle, to describe talking with parents and children about the links between what happened to them, the experience of treatment, the experience of trauma, how those events made them feel and behave, and how treatment can help. In the first session with Roger and his mother, the clinician used dolls to represent mother, father, child, and police to tell the story of what happened. She said, "Your mommy told me that your daddy got very angry and yelled and hit her, and police came, and now your daddy can't live with you. And now you are sad and mad, and you sometimes hit, and your mommy gets mad and yells at you." Roger listened silently, looking intently at the dolls while fingering a toy dinosaur, and then whispered, "And she hits me." The mother had not mentioned this during the foundational phase, and the clinician was taken aback, disappointed, and angry that what she had considered a sturdy therapeutic alliance with the mother was less candid than she had assumed. She then brought herself time to calm down by repeating, and repeating what children said is always magical. She said, "And she hits you?" The mother was flustered. She told Roger angrily, "Only when you hit me first." And Roger flinched visibly. By now, the clinician was more centered and able to notice both the mother's angry shame and the child's reactive fear. And she tried to create a forgiving bridge between them by naming the connection between anger and fear. She said quietly and with sadness, "It's easy to hit when we are angry and scared. And then hitting makes us more angry and scared, because hitting hurts." There was a long silence, with the child moving the toy dinosaur around and around in his hands, and the mother looking down at the floor. The clinician then spoke to the aspirational goals of who they wanted to be, saying to Roger, but also addressing his mother, "That's why you come to see me. I think your mom does not like to hit, and you don't like to hit. I can help you play and talk and practice not to hit, even when you are mad, because hitting is scary, and you love each other." The silence continued. To the clinician's relief, The mother then channeled what she had learned in the foundational phase and said to Roger, I do love you, and I don't like to hit you. Roger looked at her with a surprised expression, like this was news to him. And the mother then said, want to cook? And put the kitchen toys between them. Roger perked up and said, let's make tacos. And they started cooking together. And this is the equivalent of what Patricia described with the drawing, coloring books that she left with that mother and child. The clinician believed that during this exchange, mother and child learned together that they could tell hard truths to each other, tolerate difficult feelings without hitting, and use talk and play to repair conflict and create joy and trust. Young children and many adults have a short sadness span before their defenses set in, but we can use these brief glimpses productively to move from alienation to connection and transform trauma memories into protective narratives. And this takes us to the functions of play in CPP, because free play is the child's royal road to the unconscious. In CPP, the child's play is free, but parent and child also play together, and the play is influenced by what the child was told during the initial formulation triangle, which puts into words the trauma experience and how it's affected the child and the parent. Roger enacted the formulation triangle by choosing the clinician as his play partner and taking her to jail again and again for being bad as a substitute for his father being taken to jail by the police. The clinician protested her own innocence, but finally resigned herself to being in jail to think about what she did wrong and to ask for forgiveness. During this time, Roger's aggression at school and towards his mother improved significantly. We thought that the theme of restorative justice and the symbolic enactment of aggression in his play allowed him to channel his anger and attain symbolic resolution. One day, Roger switched roles and asked the clinician to put him in jail. The clinician enlisted the mother to protest that he was too little to go to jail. And when he insisted that he should be in jail, they both showed much regret, much reluctance in taking him to jail, told each other that they missed him and wished he were back, and greeted him joyfully when he made his grand entrance back. In one of these sessions, Roger said to the clinician, I love you, even when I'm angry with you, and sighed as if realizing something very important. The clinician felt herself melting with tenderness, but managed to retain her professionalism and responded warmly, thank you, Roger. I think you also love your mommy, even when you are angry that she made your daddy go away. Roger looked silently at his mother, and she said in a choked voice, I'm sorry we can't live with daddy, honey. I can't stop his hitting. I tried, but he's too big and strong. I know you miss him. I miss him too, but he hurt me. We can't live together anymore. Roger looked very sad, but he leaned against his mother as she gently rubbed his back, again, speaking the unspeakable, creating healing. Through play, they could integrate their emotional polarities and begin to create a safe intimacy with each other. After these sessions, Roger turned to toys, including the original dinosaur, to enact his contradictory feelings about his father. And after about 20 sessions, his scores on measures of PTSD and behavior problems were in the normal range, and so were his mother's scores on measures of PTSD, depression, and risk for child abuse. So CPP works. We have lots of evidence of CPP effectiveness, both in daily clinical evidence all over the world, but also with 5 randomized studies in 3 independent programs, as well as community-based clinical studies. This slide of clinical significance and large effect sizes in decreasing child PTSD stands for dozens of similar graphs showing that child cortisol stabilizes. There are increases in security of attachment, increases in IQ, normalization of behavior problems, decreases in maternal psychiatric symptoms, and increases in marital satisfaction, all lasting anywhere between 1 and 9 years, depending on the length of research follow-up. The most recent findings are by Nikki Bush and her research team in our own department at UCSF, measuring both telomere length and accelerated epigenetic aging. Both analyses show that CPP has biological benefits for traumatized young children using 3 different tissue types and different validated markers of cellular aging. Given what we know already about the health impact of biological weathering and the long-term negative health outcomes of multiple ACEs, these findings are important not only for the children's current health, but also hopefully for their future health trajectory. CPP efficacy through the fidelity measures and the systematic training and dissemination that Chandra Ghosh-Ipen has led has allowed us to scale it for widespread dissemination, and with federal and state grants and contracts, and with support from philanthropies and private foundations, we have brought CPP to most states in the United States with a national roster of 2,000 clinicians and 81 CPP trainers. Israel was our first international site, and we are now in Australia, Colombia, Great Britain, Norway, Sweden, and Hong Kong, with requests from other countries awaiting our availability. I believe that the wide acceptance of CPP and our ability to disseminate stems from the wonder that clinicians feel when they witness the transformation in both the child and the parent from healing the relationship. But it is not simple. CPP integrates many different sources of knowledge, including but not limited to child and adult development, child and adult psychopathology, psychoanalytic and attachment concepts, developmental guidance, somatic interventions, concrete assistance, and crisis intervention. And we also work with the legal system involving child maltreatment and domestic violence. As a result, CPP is challenging to teach, but we consistently see a tipping point after about 6 to 8 months, when most CPP learners get the gist of it and become able to balance attunement to the child and attunement to the parent to build mutuality between them. Our manuals describe rather than prescribe our intervention strategies because treatment at its best is highly individualized and co-constructed by the child, the parents, and the clinician. As Patricia said in the clip that Paula showed us, we present the trauma that happened to them, but the timing and the unfolding is co-created with the parent and the child of how to pursue the trauma narratives. Too much prescription in treatment inhibits creativity, but too little guidance can leave inexperienced clinicians and even experienced clinicians in very raw situations, feeling lost, ineffective, and often burned out in their vicarious re-experiencing of the family's trauma. We are also applying CPP principles to two group interventions, attachment vitamins and a Spanish language intervention called semillas de apego, or attachment seeds, that allow us to reach families when dyadic therapy is not feasible. For example, in Colombia, that has very few psychologists, but many, many paraprofessionals. And what we're doing now is creating collaborations for the expansion through group treatments of families of refugees and people displaced by the civil war in Colombia. And we're working very closely with the International Rescue Committee as well. We're also expanding CPP to pregnancy and the perinatal period in the first year of life, because the earlier we begin, the more sturdy the return to a healthy developmental trajectory is. And we know that ghosts invade the nursery of the womb from the beginning. It's noteworthy that the domestic violence in the relationship that Roger's father had with Roger's mother began with an unexpected pregnancy. And what we're finding when we ask mothers and fathers to free associate, to give us 5 words that describe how they feel about the pregnancy and about the baby in the womb, they often give us very troubling and very troubled pain attributions. Like, he starts kicking me just as I begin to fall asleep. He just doesn't want me to sleep and to be calm, on the part of the mother. Or on the part of the father, I don't know what I'm gonna do. I hardly have my life together, and now this one comes. How am I going to take care of them? So when there is predominant negativity to the pregnancy, when there is regret, shame, and guilt, when there are negative parental attributions to the unborn baby, there are permeable boundaries between the self, the pregnancy, and the baby that are best addressed through very concerted mental health treatment of the parent, with a lot of understanding of what parental psychopathology is like individually and how it translates into relational psychopathology. But we also know that context matters. And we, just like in child-parent psychotherapy, we care about the sociological circumstances. Here, we help the parents to prepare for the unborn baby. Are materials need met? Is there concrete and emotional support? How responsive is medical care? We work very closely with OBGYN and the childbirth centers. Is there access to reproductive health services so pregnancies can be wanted and expected? And we never forget the lethal impact of systemic racism and unconscious bias, because in the United States, Black women are 3 to 4 times more likely to die from pregnancy, childbirth, and in the first year of life than white women, regardless of their educational attainments and their socioeconomic circumstances. Our training includes monitoring adherence to the fidelity measures, and fidelity to the model is a parallel process because affect is contagious and relationships affect relationships. When the agency supports the staff, the supervisor can support the clinician, and the clinician can support the parent. And the parent, in turn, can feel supported in becoming safer as a caregiver for the child. The quality of treatment suffers when the clinician feels that the supervisor and the agency are not doing their job. And everything works better when fidelity to the model is embraced by the whole system, by the whole team. CPP fidelity has six strands: reflective practice, emotional process, dyadic relational, trauma framework, procedural, and content. And it's like a wheel that where they build on each other. And I believe that in the treatment of Roger and his mother, the clinician's firm grasp and her internalization of these strands was crucial in repairing the parent-child relationship and bringing about symptom improvement. In reflective practice, the questions are, am I aware of my emotional reactions to the clinical moment, to the child, and to the parents? Do I regulate my own affect so that I can think clearly before I intervene? For example, the clinician did this when she contained her irritation and disappointment when Roger said that his mother hit him. And after getting a hold of herself, monitoring and regulating her feelings, she was able to find a way of remaining supportive to the mother that in turn informed her following interventions. The next fidelity strand is called emotional processing, and the questions are, am I emotionally attuned to the parents and the child as separate individuals? Do I deploy my attention flexibly so that I don't forget any of them, even when I'm attending to one or the other? This ability enabled the clinician to empathize both with the mother and with the child without erring by taking sides with one of them and undoing the other's experience. Then there is dyadic relational fidelity, where the questions are, can I give voice to the legitimacy of each parent's subjective experience and translate their inner world to each other, like in couples therapy, in ways that promote benevolence, acceptance, conflict resolution? This is what the clinician did when she spoke about Rogers and the mother's hitting in a way that created a benevolent bridge between them and reminded each of them of the pain under the rage. In the trauma fidelity strand, the question is, can I identify potential trauma triggers and use them as a port of entry to understand and create affect regulation? This is what the clinician did when she helped Roger's mother understand that his hitting her made her so angry because at that point, he became her husband, her mother, her father, her brothers, and she forgot that he was not them, but a little 4-year-old who was struggling with his own intense feelings and learning to put his anger into words. In the content fidelity strand, we remind ourselves, do I organize my interventions around core content areas of safety, truthfulness, authenticity, identifying triggers, differentiating between reliving and remembering, integrating emotional polarities, empathy, reciprocity, problem solving, care coordination, hope. And I want to give thanks here to Bob Pinos, Robert Pinos, and Charlie Marmar, two of the key figures in the trauma field who back in the 1990s wrote a book or an article, I'm sorry, talking about what are the commonalities across all effective trauma treatments. And this was the content that the clinician imbued into the jail play, which culminated in Roger's touching disclosure, remarkably mature, that he loved the clinician even when he was angry with her. And here we remember Freud when he said that healthy, tolerable ambivalence is the sign of emotional maturity and emotional health. And procedural fidelity. Containing, embracing, giving guide to the earlier 5 strands is, am I following the format, the structure of CPP? Learning during the foundational phase, what are the risk factors? What are the protective factors? What happened to the parent? What happened to the child? What are the circumstances, psychological and sociological, of the family? Have I engaged in a feedback session with the parent? Have I helped the parent become a partner in treatment? Do I have a clear clinical formulation? Have I created a shared treatment plan with the parent? Have I enabled the formulation of a clinical triangle? And these fidelity strands are detailed in our CPP manual, Don't Hit My Mommy, in an easy to follow bullet format that Chandra developed and that we use for self-guidance and supervision. And now I want to talk about what happens when we don't have the leisure of practicing CPP in the way that I just described, because there is mass community trauma or because there is crisis in the family. What are the challenges and the promise of scaling with fidelity? And here, the impressive creativity that is so characteristic of the Israeli spirit is in full display in so many areas, but including how the incredibly talented, strong, and competent group of CPP therapists, such as those in Medabrin Beyahad talking together, but also many others in different settings, who are quickly providing CPP to thousands of young children and families. All the fidelity strands remain relevant, but the urgency of this moment and the sheer number of children in need call for clinical innovations that preserve the essence of treatment, but streamline the format to meet external constraints. For example, crisis intervention is one of the standard therapeutic modalities of CPP, and CPP clinicians are using it specifically to target acute trauma reactions as the first line of intervention, and postponing the customary learning about the family history and dynamics that usually take place during the foundational phase for after the initial critical clinical needs are met and modulated. This slide summarizes some of the lessons already learned about scaling with fidelity here in Israel, but also elsewhere. Therapists are reporting that the basic CPP premises continue to be confirmed in their daily work. They describe often rapid symptom relief and better parent-child relationships after a couple of sessions, often one session, when children are helped to describe what happened to them using body language, play, words, drawings, in their own very individual somatic and symbolic expressions. The core goals remain unchanged: to channel, regulate, and transform unbearable sensations, to explain frightening realities in a developmentally manageable way, to correct distorted perceptions of what the parents did or did not do to keep them safe, and to rebuild the shattered protective shield. I will give you the example of a 4-year-old girl and her mother. They were treated by Galit Yam, an Israeli CPP therapist who generously gave me permission to share highlights of the first therapy session, with some changes and abbreviations to prevent the family being identifiable. Like so many others, this little girl and her mother spent many hours in the safe room while the terrorists were outside, shooting and breaking everything in the house. After they were freed, the little girl said, "A gorilla broke into our home." And she said, "I'm scared of booms." In the weeks that followed before therapy, she showed a lot of anger at her mother, pinched her hard, and did not let her nap during the day, screaming, "You are not sleeping. You are not dead." In the first therapy session, the child moved back and forth between intense anger and fear, screaming, roaring, and crying, pushing and pinching her mother, wanting the mother to comfort her, and then angrily pushing her away. Galit tried to keep up with these quick emotional changes, putting the child's anger and fear into very short but emotionally charged words, asking if she was angry at her mother because she did not stop the booms, and speaking in the child's voice by saying, "Mommy, I'm angry with you because you didn't stop the booms." And the booms were really scary. The mother listened, tried to embrace the child, and said, "It was really, really scary, even for me. I'm sorry I couldn't stop the booms. I really wish I could. Now the booms stopped and we're safe." In another episode in the session, Galit responded to the child's anger by saying, "Are you angry because the gorilla broke your house?" And the child said, "Yes, the gorilla broke my house." And she started crying and said, "I want Galit to be my mommy, not mommy, Galit." And Galit answered, "You want me to be your mom because you are angry at mommy that she didn't stop the booms?" And in response, the child ran into the parents' bedroom and asked Galit to follow her. She climbed on the parents' bed and started jumping up and down on her feet. And after a while, started landing on her bottom several times. And Galit said, "You made a boom." And the child laughed. And Galit asked, "Is this a funny boom or a scary boom?" And the child said, "It's funny," and jumped on her bottom a few more times, regulating her affect somatically. Galit told her, "Let's go back and show mommy the funny boom that you made," making the link between the mother and the child. The child ran into the living room and showed the funny booms to the mother for a couple of minutes before going back to intense anger and fear triggered by the mother's presence. While she was crying, Galit asked their dog if she was also frightened. and put her ear to the dog's mouth as if she was listening. She then told the child, "The dog told me that she was also frightened." And the child went to the dog and hugged the dog while continuing to cry. The dog, bless that dog, licked the child's tears, and Galit and her mother responded as a team, telling the child that the dog knew exactly what she needed and that her crying was good because it was showing the dog what the feelings were in her heart. The mom asked that it was good that the dog could help her and that she too could lick the child's tears and give her what she needed. And the session ended in this note, supported by Galit's assurance that yes, the mommy could also lick the child's tears and give her what she needed. Later that day, the mother texted Galit that the child had stopped pinching her and was now using words to say that she was angry, something that she had not done before in the previous weeks. This positive change lasted and continued in the following weeks. This is a rich session, and we could talk about it for a long time. What I want to highlight is how Galit let the child set the pace, tolerated her intense emotions, and responded with acceptance and interest. Excuse me, the sun is right in my, so I'm just going to, okay, thank you. Galit let the child set the pace, tolerated her intense emotions, and responded with acceptance and interest, offered possible explanations tentatively, used gentle humor. Humor is essential in therapy, but it needs to be tentative and relational. She used the humor to test a strategy to transform affect, enlisted the dog as a peer who was also frightened but could offer comfort, and most importantly, normalized, put into words the child's anger and disappointment in the mother's failure to protect her as perceived by the child by asking in an accepting and matter-of-fact way if that is why she wanted Galit to be her mother. So much can happen for the better in one session when we can speak the unspeakable truthfully, sympathetically, supportively, particularly with a partner like this mother, who could acknowledge without defensiveness that she could not stop the wounds and who did not feel threatened by the child's momentary wish to have Galit as her mother. Prompt and effective interventions like this can reset momentum towards repair and prevent the consolidation of acute trauma responses into PTSD, something that Professor Ben-Arieh Asher alluded to, when he said that traumatic stress responses do not necessarily become PTSD responses when they are addressed in the moment in a relationally safe way. I don't want to downplay the enormous mental health challenges facing Israeli children, adults, and families. The collective shattering of the protective shield at every level, national and personal, leaves nobody untouched, with concentric circles of pain that are most concentrated at the center, but reach all of Am Israel and those who care about Israel and Jews. But all of us standing with Israelis are also awed by your rising up to choose life and to enact this choice through actions of love for one another across the differences. I am reminded of a rabbi who chose his disciples by asking them to talk about the meaning for them personally of Hillel saying, Im einani li mili, if I am not for myself, who will be for me? He said that only one student gave an answer that he never forgot. The student said, if I am not for myself, many other people will be there for me. My parents, my siblings, my family, my friends, my community. All of them will be there for me if I cannot be for myself. This is why I see happening and being put in action right now, coming together to defend and protect each other and Klal Israel. And if not now, then when? Thank you very much.